or 08155 917 917 if you decide that you want to call today. It's 07000 917 917 or 09155 917 917. Our toll-free line is also available, 0800 1235 917. Now that it's out of the way, let's get into it. Dr. Collins, can you briefly explain what endometriosis is?
Okay, thank you for that question. So endometriosis is a condition that is characterized by the presence of the inner lining of the womb. Usually we call it endometrium. That's the inner lining of the womb where a baby stays and grows. Okay. So basically in this condition, you find that inner lining outside of the uterus. So you find the inner lining also in certain areas of the body, like in the pelvic, on the pelvic ligaments, on the ovaries, in the tubes. Even for some people, you see it in the bladder, okay, and of course in the bowel. So what this means is that this condition can cause chronic inflammation, pelvic pain, and of course infertility. So for the endometriosis, what we tend to see is that the commonest complaint from people is always pain. It's heavy flow and pelvic pain. So usually for a young lady, a woman of reproductive age, once the woman comes to us and then she's saying that she has very severe menstrual pain or pain, severe menstrual pain and of course heavy flow and all, usually our minds already starts to point towards the direction of endometriosis. This condition is present in 10% of women of reproductive age, 10%. So that means 1 out of every 10 women has endometriosis, okay? And it is said to cause infertility in 30% of women that have this condition. So we have also seen cases where the woman has endometriosis, but she doesn't even know that she has endometriosis. And these cases, we find this case up to 20% of women that are being screened for infertility. So you tend to see people where we usually call the silent endometriosis, even though there's really nothing like silent endometriosis. It just means endometriosis that has not progressed to the stage where it will cause symptoms and cause problems. So this endometriosis can be classified as being superficial or deep, depending on depending on how if the lesion is infiltrating or if it is just superficial on a particular structure. Okay, and it has different stages. So I think after this stage I'll just end. So it has different stages. It has about 4 stages. We have the stage where it is said to be minimal. At this stage, there are implants. For these implants, there are really no adhesions. It's not causing adhesions, The next stage is the mild stage. In the mild stage, you start to see mild formations of adhesions from these endometrial implants. Okay, you start to see adhesions connecting, just mild adhesion. In the third stage, which is called the moderate stage endometriosis, usually at this stage, you start to see cysts form on the ovaries. And usually at this stage, your adhesions start to become more and more extensive. And of course, when we say more and more extensive, it means that the symptoms become more and more even excruciating and more severe. Okay, yes, and even the pain becomes even more and more excruciating. Okay, and then in the last stage, which is called the severe stage of endometriosis, usually at this stage, you get a lot of dense adhesions. Adhesions are just scar tissue that are formed inside of the pelvic cavity, connecting to even structures, okay, connecting to structures like the ovaries and and even the pelvic ligaments and the rest. So basically, in this severe case, of course, the symptoms become more severe. There are presence of large endometrial, and usually we call them endometriomas. They are large endometriomas. Endometriomas are simply cysts that are formed on the ovaries, in women that have endometriosis. Okay, and then of course, we said that there will be multiple, both superficial and deep infiltrating lesions. So I think I'll just stop here to allow the conversation flow. Yes, sir.
Okay, thank you so much, Dr. Collins. How common is endometriosis among women of reproductive age? I'm not going to lie. I think the first time I heard about endometriosis was 2023, which is interesting. PCOS, I was very familiar with. I was sort of familiar with PCOS in 2023. Before then, but I remember that 2023 was when I really heard about endometriosis. or maybe the year before, there's a popular actress that had come out to talk about endometriosis. Then a friend of mine as well had said she has a terrible case of endometriosis and she has to use a particular type of painkiller that I used post cesarean section. I was like, hey, how come? But so how common is it? And when women say, oh, they have painful periods, is it more than that? Should they go and check it? Because people just say, oh, your periods are supposed to be painful. Do you understand what I mean?
Yeah. Okay, well, truthfully, like I said earlier, endometriosis is found in 1 out of 10 women. So if you sample 10 women, chances are excellent 1 out of them actually has endometriosis. Yes, might not be symptomatic at the time you're finding it, but then of course, being that it's a progressive disease, at some point, as far as that diagnosis has been made, at some point it will start to become problematic and symptomatic, okay, and can even cause infertility. So it doesn't mean that everybody that has menstrual pain or dysmenorrhea has endometriosis. Nah, it doesn't mean that. But then, like I said, once we're discussing with the client, and then the client is saying, I have very severe menstrual pain, just by default, our minds start to switch to, is there a possibility that this client has endometriosis? Doesn't mean that it's a confirmation. No, we still have to subject such a client to evaluations, investigations to make our conclusions. Yes, so, and it's possible for a woman to have painful menstrual periods. You see that a lot in most teenagers, especially people who are just seeing their menses. They usually experience a lot of pain when they see their menses. I would say it's also very subjective because now, relative to somebody who has been seeing menses for a couple of years, maybe for like 10, 15 years, they might not judge that this thing is so painful. You understand? But so the teenager started seeing menses, and then it prevents her from doing whatever she has to do. She's throwing up and all the water. I mean, I've usually seen somebody, when she sees her menses, she throws up, she stools. Yes, like it's just a very atypical finding, but yes, it exists. But I mean, today she has a baby. She never had any complaints. She never had any struggle in trying to conceive. So these are some of these pictures or scenarios. So basically, not everyone that has painful period, please, has endometriosis. But then, being that painful period is the hallmark. In fact, it must be present in endometriosis. So we do not put a blind eye to it. We always generally just trigger us to just like, okay. So how long have it been? You just have to for that. Yeah. So basically, 1 out of 10 women have endometriosis. That is how common the condition is. But then sometimes people do not quickly get that diagnosis of endometriosis, because, like I said, it would require some extra interventions. And usually for some people, it's at the point where they start to have difficulty in conceiving. And then they go back to the fertility physician and he's probing, he's doing evaluations, he's doing tests. Accidentally, they just tell you, madam, we are seeing something extra. There is endometriosis. And this might be the reason why you're even having the delay in the first place. Okay?
Right.
Yeah.
Okay, we mentioned painful periods, but are there other signs or symptoms that women should watch out for that tells them before they now go to the hospital, say, I might be having a terrible case of or maybe this might be endometriosis, things like that? Yes.
Okay, yes, thank you for that question. So basically, painful periods are not the only symptoms that women, it's not the only symptoms that women experience. So basically, painful intercourse, so usually we call that dyspareunia. So women can also experience very painful intercourse, like the pain that even makes them to become very advanced to having sexual relations and all of that. So basically, painful intercourse, and then heavy bleeding. So women will even experience what we call menorrhagia, where they bleed heavily. So usually, once you see painful periods, painful intercourse, and then that heavy bleeding, honestly, you're one step closer to just making that diagnosis. Again, it doesn't end there. You also find certain people have lower back pain. Some people, even when they see their menses now, they start to bleed. Okay, when they urinate. So usually we've seen cases where the woman now experiences hematuria, where when she's seeing her menses, she's peeing blood. The reason is because the endometrial implant is now present inside of the bladder. So when she's seeing menses, that endometrial implant, that inner lining, okay, a portion of it, and it's like an ectopic, what do I call it now? So you find that endometrial lining inside of the bladder. So while the woman is bleeding from the womb, that bladder, that implant in the bladder would also be bleeding. So she'll be seeing blood. You've also seen cases where the woman starts to pass blood in her stool when she's seeing menses. When menses stops, it stops. Okay, so basically these are some of these findings, and of course infertility. You find people having delay in getting pregnant. Like I said, mild form of endometriosis, okay, or mild endometriosis is one of the causes of unexplained infertility. So I think some time ago we spoke about unexplained infertility, where the couple have done all the tests that they know to do. Everything is normal, but they are just not getting pregnant. We've seen that mild endometriosis can actually prevent, can cause unexplained infertility. So just to reiterate, painful intercourse, painful menses, heavy menstrual flow, and delay in getting pregnant can also be the other symptoms. Of course, not leaving out passing blood in the stool, which of course is not very common, but then we've seen it. Okay, and then we've seen a case where the woman had what we call an umbilical lesion. So when she's seeing her menses, the blood is coming from her navel. Yes. Oh yes. So that's an umbilical lesion. So that's one form of endometriosis. Oh yes. I've also seen another client where for this particular one, the blood isn't flowing from the navel, but then whenever she's seeing her menses, there's always this swelling on her navel. So it's still the same thing. There's an implant just right there. So basically, it does that it has not gotten to the point where it starts exuding blood, yes, when she's seeing menses. So basically, these are some of the symptoms that that are present in endometriosis.
That's present. I mean, we've talked about signs and symptoms, and there's some women that I'm pretty sure do not even know do not even know they have endometriosis until they've been trying to get pregnant and they realize it was endometriosis. But can it also exist without symptoms?
Oh yes, so endometriosis can exist without symptoms. Like earlier, we spoke about some people having what we call maybe silent endometriosis. In this way, there's something like it's just saying that it's asymptomatic. Okay, so where there are no symptoms, no painful menses and all the whatnot, because most likely the disease is still in its infancy. Okay, so that's not gotten to that stage. Because remember I said it's a progressive disease. So the moment that diagnosis has been reached, it will only get worse. Okay, it just keeps on progressing to the stage where it starts becoming from mild stage, moderate, severe, So basically, about 20% of women, okay, have endometriosis and they don't know about it. Yes, and they are diagnosed with the condition when they actually go for fertility evaluation. Okay, maybe fertility for some reason they are experiencing delay in getting pregnant, so they go for evaluation, and then of course, the doctor accidentally finds it, and then of course breaks the news to them that okay, madam, there's endometriosis. So in 20% of women, it is asymptomatic.
Right. So let's talk treatment. How can a woman who has whether a mild case of endometriosis or the really, really serious one, can they have children eventually? Is there anything that they need to do, or is there a treatment that they can take that would help them, that would improve fertility for them?
Okay, so basically, first off, for a woman who would like to know whether she has endometriosis, of course, she has to go through first off diagnosis. So we have to diagnose it before we get to that point. So for the diagnosis, of course, it would include just the symptomatics. You're talking to the patient and she's telling you, doctor, if I want to see period, it's like World War III. If I remember the patient who actually said that. So, such expressions, you already know that, okay, this woman is having severe dysmenorrhea, okay, and then heavy bleeding. I also have the woman will tell you that she has heavy flow, painful intercourse, and of course, I've not been able to get pregnant. So you use the symptomatics. That's number one. Number two, you do a scan. Okay. Number three, MRI can be used for diagnosis of endometriosis. And the gold standard is to do what we call laparoscopy. Laparoscopy is a type of investigation where a camera is passed, into the tummy. Okay, not into the tummy, but into the pelvic cavity, just to try to see. So usually you'll be able to see some of these endometrial implants here and there, and of course you're able to even see the extent of adhesion formation inside of the pelvic cavity. So after that is done, of course, we talk about treatment. Okay, so for treatments, the goal is to either first of all improve the symptoms like that the patient is experiencing, to improve it, and which is pain. Usually the pain is always the one that is the first point of call. So it's pain. So of course there are medications that can be used, painkillers, and then of course certain medications like the oral contraceptive pills can also be used. It also helps, they give an added advantage for pain relief. Okay, because some of these contraceptive pills, they have what we call anti-proliferative effect. Okay, so this is big grammar. So what it means is that it prevents the lesion from progressing. Okay, so yeah, so they just have to have this that's the anti-proliferative effect that they exert on those endometrial lesions. Okay, then after that, of course, there are certain medications like the GnRH agonists, drugs like Zoladex, Goserelin, Duprolide, some of these medications, they also have this anti-proliferative effect on the lesions, on those endometrial lesions. The reason why the woman experiences the pain and all is because the lesion is growing, so to say, it's becoming extensive. Even the endometriomas, the cysts that are formed inside of the ovaries, they are also growing. All of these things are the reasons why the woman will be experiencing infertility, pain, and all the symptoms that she experiences. So what these medications they do, they help to shrink the lesion, and as a result, help to improve the symptoms that the woman experiences. But the only drawback with using some of these medications, like I said, is that while using especially the gonadotropin, the releasing hormone agonists, is that they will prevent ovulation. Yes, they do that. So endometriosis is a hormonally dependent disease. Okay, so it is highly dependent on estrogen. So what these medications they do, like the GnRH agonists, they help to, of course, to cut out estrogen from the system, so that the woman, those lesions will not be able to feed. It's like cutting out the fuel. Like, okay, let's say it's like a woman who sees maybe a gas just bringing out fire or something. The only thing you have to do is just to turn off the canister so that fire goes off, for instance, so that the cooker or the burner or whatever goes off. Exactly. So that's how it is. So that's what you're doing. You're cutting out the fuel, okay, the supply, that hormone that supplies these endometrial lesions to cause problems. You're cutting it out, which is estrogen. So that's what the GnRH agonist does. So when you give it. So besides that, for a woman who is attempting to get pregnant, okay, of course, some people might have to resort to doing surgeries, laparoscopic surgery. That's for women who have very extensive lesions and then of course, that are also present in strategic locations like on the tubes or, and even on the ligaments. So, just to reduce their pain, some people might need to do surgeries, like the ones that have distorted the pelvic anatomy. Usually it's adhesions that will distort the pelvic anatomy. And these adhesions will form because of the presence of these endometrial implants on these ectopic sites. So basically, surgery can also be done just to, realign the pelvic anatomy and so as to help the woman conceive again. So what that means is that laparoscopic surgery is also a modality for treatment of endometriosis. Usually there are different ways to do this laparoscopic surgery, laparoscopic ablation or just the normal surgical laparoscopic excision of these implants. Okay, and then for a woman who is trying to conceive again, okay, there are fertility treatments that can also help her to get pregnant, like IUI. Okay, you can do intrauterine insemination in mild forms of endometriosis. Mild and the minimal stage, yes. So when we see stage 1, which is the minimal stage where there are little or no endometrial implants, out there, so basically that's minimal form. In the mild form, of course, there are endometrial implants with mild adhesions, okay, around. So basically, in these two cases, you can do IUI, especially if the woman is under the age of 35. Okay, but as the disease progresses, of course, we also have to step up the fertility intervention in order to help the woman get pregnant. So in the moderate and the severe cases, where you now start to see cysts present on the ovaries, a lot of adhesions here distorting the pelvic anatomy, the best decision for such a woman, and if the woman has also crossed the age of 35, the best decision for now, stage 3 and stage 4 endometriosis and age above 35 is IVF. It's IVF. For some other persons, usually if they are diagnosed with the disease early enough, okay, usually we start to tell them to do what we call family planning. But family planning in this case does not mean taking contraceptives to prevent pregnancy. No, it means we have to start counseling them. So you have to give birth early because this condition is a progressive condition. Yes, so today that we are seeing that it's still okay that we still have eggs present in the ovaries, and all, and you're still seeing your menses the way you should, it's better you get pregnant as soon as possible and give birth. For some other person, you start to talk to them about fertility preservation, where they have to freeze eggs. So for somebody who's like, no, I don't want to go down that route. Oh yeah, what is the next thing for me? Then we start talking about fertility preservation, where you have to get eggs saved for future use for the woman. The reason is because, like I said, endometriosis is a progressive condition. So as the woman ages, the condition will continue to attack the ovaries, attack the eggs, okay? And of course, makes it very difficult for her to get pregnant. And it does this through a series of events. So usually endometriosis can cause infertility by preventing the egg and sperm from meeting. So when we find these implants inside of the tubes of the woman, the tube is the site where the egg and the sperm meet. The endometrium just acts as a barrier. The egg cannot meet with the sperm cannot pass through to meet with the egg. So it does that. It discovers the pelvic anatomy through adhesion formations that will just change the way the alignment of the uterus inside of the pelvic cavity, and this will not allow for conception. It also causes what we call impaired endometrial receptivity. So what this simply means, after the egg is inseminated by the sperm, is fertilized by the sperm, I beg your pardon, an embryo is formed. That embryo will move from the tube into that endometrium, the inner lining of the womb, to implant. So what it does is that endometriosis makes that endometrium, that inner lining, it makes it very unconducive for an embryo to implant. Yes, it impairs implantation. So the substances that should be produced to allow an embryo to adhere, to gum, or to, I'm trying to use a word that is related to what we call it implants, for an embryo to implant. Okay, these substances will not be produced because of inflammation. Okay, so and as a result, the woman will not be able to get pregnant. So this is the reason why. Yes.
Sorry to cut you. So so what happens in the case of IVF? Because if the embryo cannot implant, isn't the same thing the IVF? Because for the IVF, that's the egg and the sperm is fertilized outside of the woman's womb. The egg and then it's viable, and then it's now injected. So what happens in that case if the endometriosis is not even allowing the endometrium to be conducive enough for the embryo to take?
Beautiful. That's a beautiful question. So this is where the pre-IVF treatments come into play, where certain medications like the gonadotropin releasing hormone agonists are given, just to make the endometrium just to be quiet, just to make all the inflammation, all the misfires here and there to just be silent before you now initiate the IVF treatments. So as a result, it's not a way to trick the body to, so basically after giving this shot of so everything just becomes calm, okay, before you start giving, because like I said, this condition is hormonally dependent. So when there's a lot of misfire, that they thrive. Those endometrial lesions, they thrive. They love that kind of setting where the woman keeps on seeing her menses, estrogen is just being produced, and they are just enjoying themselves, growing, causing problems, causing pain, and all the symptoms. Oh yes. So, but when you give all this medication, they cut out estrogen from the system for a period of time, usually around 3 to 6 months for some people. Okay, that's how we do it. So that's how you do it. You give 3 to 6 months just to make these lesions to shrink. Okay, so these lesions will shrink. The only problem with this treatment is that the moment you stop taking these injections, they start to grow again. It's just like the same thing. What happens in fibroids? Fibroids will also depend on estrogen to grow. So whatever you do to cut out estrogen from the system will shrink the fibroid. The moment that thing is removed, the fibroid starts to grow again as far as the woman starts to see menses again. Okay? So basically in IVF, there are what we call pre-IVF treatments, so where we give all these medications just to make the system to be quiet before you initiate the IVF treatment.
So the 3 to 6 months, is that the pre-IVF treatment that the woman takes, or is that is that how long the endometrium counts down?
Okay, yes. So it's also going to be subjective to the let me say the discretion of the doctor. So the doctor who has evaluated the patient knows that, okay, this is how long it will take me to actually get good shrinking of those lesions and just to make all the symptomatics to be abated and all of that. You understand? So it is not like a one size fits all. There's certain people you give even just a shot. So there was a client who I saw last year. Okay, she had a cycle of IVF the very first time. It failed. So after the failure of the IVF, she came to us and then she told me that she started to see fluid. That whenever she sees menses, this has never happened before, but now whenever she sees menses, it comes out from another. Like it was never there before. She never had it because we've known her for a while, So we were like, okay, oh yeah. So we placed her on this gonadotropin releasing hormone just for a month, and then she did the IVF, and then she got pregnant. As I'm talking to you now, she has a baby. You understand? So there's still a reassuring aspect of all of this discussion, so that anyone who is hearing does not think
it's not feeling like it's all negative.
This one, there's no hope. No, there is hope at the end of the day. So basically, for such a woman, you see, we only give her a month's dose, okay? But for some other persons, it could be up to 3 months, could even be up to 6 months, depending on what the doctor is trying to achieve, especially for people that have very severe case of endometriosis with all the cysts and all the whatnots.
In this woman's case, her case was mild then.
Well, it is safe to say our own case. It's safe to say our case was between mild to moderate.
I'm asking the question because I'm curious to understand how the drugs they abate the fieriness of the adhesions, the lesions on the
lesion. Yes.
Yeah, but then when the baby is there, are they not there anymore, or are they still doused?
Okay, good, beautiful. So basically, when the baby is there, when the woman gets pregnant, okay, there's a predominance of progesterone. Okay, not estrogen, but there's that predominance. So the placenta just keeps on producing all the progesterone. So that is what really supports the pregnancy. Yes, doesn't mean that estrogen is not in the system, but relative to the quantity or to the volume of progesterone that is now, supporting the pregnancy, it's really wouldn't do so much. Okay, yes, in this case, yes.
I understand that. Yes, because I can relate with that, because when I was pregnant with both children, I think for my first child, I was having a threatened miscarriage. Well, I mean, I eventually still miscarried that baby, but they wanted to quickly give me a progesterone injection but then I still miscarried that baby. But with my second child, I remember being given progesterone injection it was for like 9 weeks. I don't know, maybe my 4th week to my 16th week, I can't remember, but that was how long it was, because they said, maybe they were giving me the injection to aid the pregnancy, so I understand that. Because pregnancies, there's less estrogen and
more progesterone.
Okay. All right, I'm learning. Yes. I was going to also ask, you mentioned surgical options, that's the laparoscopic surgery for the woman. But has there been any incident where they have to take out the ovaries? Because obviously the lesions are growing on the ovaries. So if they take out the ovaries and the womb, does the woman still have, and she won't have endometriosis anymore because she won't be seeing her period anymore, right?
Beautiful. So endometriosis. So the fact, truthfully, there's no cure. There's no usually we say there's no cure for endometriosis, but then of course hysterectomy, which is what you're just trying to explain, taking out the womb, the ovaries, can become a final decision for the woman, okay, especially for women who have maybe already given birth, okay, for instance, so that can become a last resort for them to just help, because like I said, once there's no estrogen in the system, then of course the woman wouldn't have any problems, okay, because this condition is estrogen dependent, okay, and then of course the estrogen will come from the ovaries. So once you take out the ovaries, the uterus, of course, the woman is not seeing menses again and all of that. Of course, all the symptoms and everything disappears, because there's no feeling of those lesions anymore. So the lesions will shrink and then they just shrink and become what's the word now? I don't use the word non-functional, but maybe atretic, something like that. Yeah.
Right. Okay. There's just still hope for people who want to have, for women who want to have children, regardless. Yeah. Okay. Are there success rates for? I mean, you mentioned one, but the success rates for women who have endometriosis, whether mild, whether moderate, whether severe, what are the success rates with finally having children?
Okay, so basically, we have to know that for women, the pregnancy rates, okay, in women that have endometriosis is lower than women who do not have endometriosis because of the, like we said, because of all the ways in which it causes infertility, prevents ovulation, it causes it impairs uterotubal transport, prevents the sperm from mixing with the egg. That's what that just simply means. Okay, it can also be the reason why there's tubal blockage. Okay, because of the presence of the endometrial implant inside of the tubes, and of course, it also impairs implantation. By altering endometrial receptivity. Okay, so and basically that's some of the ways it causes infertility. So with that said, it just means that once a woman has endometriosis that can cause all of these things, then of course it will also prevent pregnancy. So pregnancy rates, of course, in women that have endometriosis is lower than women who do not have endometriosis. We're seeing rates at 30% and below. That is for people even coming for IVF now. Okay, in natural conception, it is even slightly, it's even of course lower than. So the chance for a woman to get pregnant naturally, okay, bedroom pregnancy without endometriosis and all is around 25%, okay, per cycle. Okay,
that's
so
without
endometriosis per cycle.
Wait, did you call it bedroom pregnancy?
Yes, I call it bedroom pregnancy. So that is natural conception.
Yeah, I was like, what are you saying? Okay.
No, usually we try to just coin some of these words just to give an expression to what we're saying, especially to people who are not too literate.
I get you.
So it's just slightly lower. Yes, even in IVF and in natural conception, it is lower. Yes, it is lower.
That's for women with endometriosis or without?
No, for women with endometriosis, their chance to conceive naturally is lower than women who do not have endometriosis. And similarly, in IVF treatment, women who are coming in for IVF treatment and they have already been diagnosed with endometriosis, the chance for them to also get pregnant is lower than women who do not have endometriosis. Yes. Yes.
Wow. Okay. What about diet, exercise, stress management, lifestyle changes? Are they effective in improving fertility? Do they make a difference at all for women with endometriosis?
Okay, yes. So basically, why they do not serve as a cure, they kind of, like I said, they cannot be used as a cure. No lifestyle medication can cure endometriosis. Okay?
As opposed to PCOS?
Yes, as opposed to PCOS. So lifestyle medications are very, very beneficial for people who have polycystic ovarian syndrome, but not for endometriosis. Okay? Well, the truth is, lifestyle medications can actually help to improve the general reproductive health. I mean, somebody, okay, now let me just try to say this. If you're carrying a coal, charcoal that is just, it is hot, you don't want to put it close to a petrol, even though it is hot. It's not lit, but I mean, it's hot. You don't want to put it close to petrol or diesel because it will just ignite. Okay, so that's how it is. So you already have the diagnosis. The person already having the diagnosis, endometriosis, a chronic, a condition that's characterized by chronic inflammation and all the whatnots. You don't want to start engaging in certain lifestyle habits that will mess up the hormones and even make matters worse. Taking alcohol, smoking, and all the whatnot. So usually we are advised that women who have endometriosis, of course, they try to improve their stress levels by trying to sleep, meditations, if possible, use supplements, avoid pro-inflammatory diets that sponsor inflammation and mess up the hormones of women in general, hormone disrupting diets like fast food, processed food, all the things. So we advocate for engaging in a balanced diet, vegetables, omega-3 rich in omega-3, avocados, fish, dairy products and all the whatnots, rather than be taking bread and the rest things that will just mess up hormones. And of course, we also advise that women who have endometriosis keep a healthy BMI. Okay, let their body mass index be within the reason is because being overweight again would disrupt hormones, and of course, this is already what endometriosis is already doing. So you don't want to add fire upon what's the word?
Fuel to fire.
Fuel to fire. So basically, that is the place for dietary or lifestyle modifications in endometriosis.
Wow, thank you so much, Dr. Collins. Do you have a final word for our women? I know you've been saying it here and there, but is there something you want to say to women who are struggling with endometriosis, even for their family members, that you're a spouse to somebody that has endometriosis, maybe it's your brother, your sister? What's the final word that you want to say to us today?
All right, thank you. So basically, endometriosis being a chronic condition is one that comes with a myriad of symptoms, and one of which that I didn't mention, I think I just left it out, is a psychological symptom. It can result in depression, a woman feeling like, okay, why is my own different, and all the whatnot. So women who have endometriosis are already going through a lot, and this I know because I have someone close to me that has endometriosis, a friend, actually sister to a friend who has endometriosis, and trust me, she's barely 30 and already experiencing headache. I can tell you, when I mean headache, I don't mean literal headache. I mean pelvic pain, So basically, they're going through a lot. So, and the women who have endometriosis, they need all the support that they can, both from family members, even to get support from even fertility counselors and even support groups. It is going to be key in helping them to, go through this condition and still be able to come out from the brighter side of the tunnel anyways. So with that said, so I think it's important that partners to women who have endometriosis also become very encouraging and very supportive. Okay, it is not truthfully, it is a tough, let me use that word, yes, handling or battling endometriosis can be tough, even for physicians, yes, even for doctors. Okay, so this is the reason why the women with endometriosis, they need all the support that they can. And so just to say a final word, so basically there's light at the end of the tunnel. Yes, even with respect to getting pregnant, of course, like we said earlier, that there are means in order to help the woman get pregnant, interventions like IVF or even the IUI, depending on the stage of the disease. And even some women can still get pregnant even naturally. Yes, especially in case of mass endometriosis. So there is always a way out. Yeah.
Thank you so much, Dr. Collins Aborojek, for today's free consultation on endometriosis and conception challenges. It's so good to have you back, and today was such a very, very educative episode today. Thank you so much, Dr. Collins.
You're welcome.
Dr. Collins is an assistant medical director and fertility physician at St. Ives Specialist Hospital in Abeokuta. If you want to get in touch with him, you can download the Teledoc app on Android or iOS, and then you can get through to him. Thank you so much, Dr. Collins, once again for coming.
Very pleasure.
Do enjoy the rest of your day. Okay, you're still tuning to Women Radio 91.7, and we still have great, amazing shows for you, so you don't want to go anywhere. Radio Doctor is coming back tomorrow at 10 a.m., so you're going to join us for another edition of Radio Doctor. Many thanks to the producer, Aisha Sani, and to Benjamin and Rachel over in the studio. Many thanks also to the executive producer, Tomu Kiwale Shanaya, for today's edition of Radio Doctor. My name is Fumi Bambara. As always, do have a healthy day. Enjoy the rest of your day.
Here we go. 3, 2, 1, 1, 1. I don't know if I know that. Keep it locked. I should have bought your flowers. Turn your radio on. We are WFM 91.7.
Weakness does not need permission to take over your life. It only needs space. And every time you choose comfort over challenge, every time you choose avoidance over action, you are giving weakness exactly what it needs to stay in control.
For Amazon, Canada, sacrifice all of y'all, some family, follow them up, when you visit up, cash, come back, try jump up and down, go by the water, get gunshot and drown. Like every part of you in Dumbledore's house, get the darkness cause you're on dead right now. Nobody cry because your tears just won't count. Everything was nice but now your luck run all out. Grab me an eye if you don't hear from my mouth. You listen this nice but you just have to find out. Can I sacrifice all of y'all?